Without further ado, I'm going to now introduce our first speaker. And this is Professor Becher, Professor Harald Becher, who joined the University of Alberta and Mazakowski Alberta Heart Institute in 2010. He held a position of a Heart and Stroke Foundation of Alberta, Chair of Cardiovascular Research for 10 years, and currently holds a position of a Professor of Medicine and Alberta Cardiovascular and Stroke Research Center. Harald's lecture is entitled The Value of Contrast in Stress Echocardiography. Why is accuracy in endocardial border delineation so important? With that, Harald, please do come and give us some educational lecture.
So just coming to additional guidelines. And one is of the European Association of Cardiovascular Imaging. They published a consensus paper on stress echocardiography, and this is the most recent one. And they propose in a protocol which is called ABCD imaging for stress echocardiography based on 4 pillars. Actually, they propose several more letters for that protocol. Now, this is A would be 2D echocardiography for regional wall motion assessment, B, lung ultrasound for B lines, C, quantitative volumetric echocardiography, and D would be color Doppler or pulse wave Doppler for coronary flow and or perfusion imaging. Now, this sounds complex and frightening, but the guidelines also include, or the consensus paper also includes, that the assessment of the regional wall motion abnormalities is still the first and the most important parameter, what we should do. Now, there is another guideline, Attila mentioned that, of the ESC on the management of chronic coronary syndromes. And these guidelines, they confirm what we are already using in stress echocardiography for a long time, the fact that regional wall motion assessment is a sensitive and specific marker of significant epicardial obstructive coronary artery disease. And what is significant? Significant are studies which we call high risk in our conclusion. That means 3 or more segments show new wall motion abnormalities. So assessment of wall motion abnormalities is the first thing to do, but it's sometimes tricky. And it's tricky because of the anatomy of the LV wall. You can see here that on an anatomic specimen, we have 2 layers. The compact myocardium, and that's what we want to see, because that's where we can see thickening and inward motion most easily. But that is often obscured by trabeculations, mainly in the apex, in addition to the noise which we often have in the apex and here in the lateral wall. Contrast agents, or as we call it today, ultrasound enhancing agents, can help us because they fill the gaps between these trabeculations and make it easy to follow the border of the LV cavity. And it's not only the wall thickening what we are looking at, we are looking also at the inward motion, and something which I want to stress here in the next slides, also on the shape of the ventricle, which is very important to assess images for whether they are normal or abnormal. Attila mentioned the recommendations for the use of contrast agents or ultrasound enhancing agents in stress echocardiography. And there are 2 or more contiguous segments which are not adequately visualized. What you also should do before stress echocardiography, you should ask the patient to take breaths in and out to mimic cardiac motion. If you don't see it clearly, then you have an indication for ultrasound enhancing agents. And here is just an example. These are the three apical views which we are using in stress echocardiography. We have here the 4-chamber, the 2-chamber, and the 3-chamber view in a patient with exertional dyspnea and several risk factors, and certainly an unfavorable weight for stress echocardiography. And definitely an indication for contrast echocardiography. And you see now with the contrast in the cavity delineating the compact myocardium, it's now possible to follow the movement throughout the cardiac cycle and to measure an ejection fraction, which was normal. But it's also possible now to reliably assess the regional wall motion. And I have highlighted that with the red arrows. And in all apical views, you can see wall motion abnormalities. And what you can see here, there is no inward motion. There is hardly any thickening, also seen here, particularly here in the apical inferolateral wall. So we have several areas of wall motion abnormalities. And this is one of the more rare cases where you already can make a statement at rest and not necessarily need to proceed to stress, because if you have significant resting abnormalities, and that means hypokinesis in at least 3 segments or akinesis in at least 1 segment, then that suggests the presence of coronary artery disease. It's a little bit hidden, the coronary disease, by the our images. Now, let's look at the other extreme of image quality. In stress echocardiography, we always measure the ejection fraction at the beginning of stress, and we use the Simpson's method. And when you look at this 4-chamber view, probably most of you would say this is reasonable or a good image quality to make an assessment. And it's right for visual assessment of regional wall motion. But when you want to measure ejection fraction and you go to the still frame of the end diastolic frame, it's getting a little bit more tricky. No problem along the septum. We have no trabeculations. And also here on the lateral wall, not too bad, although this noise here, or looks like noise, is probably possibly are the trabeculations, but it can be difficult in the apex. Now, in this case, certainly looking at the real-time image will help us. But look at that, the patient now we show you here, the systolic, the movement of the 2-chamber view. And in diastole, it's very difficult to delineate the border. And you see how much easier it is when you have the blood pool enhanced and clearly see the border. And that helps you to assess regional wall motion abnormalities or just to classify wall motion as normal. This is a large series of 718 patients looking at the image quality at rest and during peak stress. And in red are the columns for using the ultrasound enhancing agent, and you see practically all segments were excellent and or good, had good quality for delineation. And even at peak stress, it's almost the same. There are very few patients where there is only moderate image quality. And that has an impact on how we read stress echocardiography. This is also a study of more than almost 200 patients where before stress echocardiography comparing the reading of non-enhanced images with the readings after injection of the ultrasound enhancing agent. And just look at the line of the normal findings. There are a significant number of patients where assessment, the clinical assessment changes from normal to hypokinetic or even akinetic. And finally, I don't want to show too many data. I want to show more examples, just to remind you what you probably already have heard of, is the improved observer variability, the improved reproducibility when you use an ultrasound enhancing agents. You see here the interclass correlation coefficient for the ejection fraction, and also for the wall motion score index, much better than on a non-enhanced images, and that relates both for comparing experienced readers or experienced readers and inexperienced readers. But it's not just looking at and seeing the borders. For stress echocardiography, very important is to have unforeshortened views. Only when you have unforeshortened views, you can make a reliable assessment of wall motion abnormalities or exclude wall motion abnormalities. And this is here shown. So in the patients with normal function to start with, the good delineation of the apex, and that's here very important to look at, and showing you a triangular shape, particularly in systole, confirms that you are in the right position. And I show you that on the cartoon here. You need to intersect with your imaging plane the apex. If you are not hitting the apex, you get an abnormal, more rounded shape in systole. The ventricle is also shorter. And that's what we have to avoid, also to get reliable recordings. There is another thing when you have to optimize the plane. When you want to optimize the plane, you also want to have no foreshortening from diastole to systole. So again, seeing the tip of the apex very well helps you to decide whether this is a good recording, because when you have an unforeshortened view in both systole and diastole, your tip of the apex should be in the same position, which we have here. So Attila already mentioned the Everest trial, and the Everest trial, Dr. Eason will talk in detail about that, but I want to just get two numbers of the Everest trial. The Everest trial is this big UK trial. I think the best stress echo study performed during the last decade to show the value of stress echocardiography. And you see a majority of patients were given contrast agents. And I think that contributes to the excellent result for the negative predictive value, which is very high and makes us very confident if we have unforeshortened good views with good delineation, that a patient who is discharged with a normal stress echocardiogram doesn't come back with any major cardiovascular events within the next 6 months. Now, let's go to some abnormal cases. So what I will show you now, a series of recordings and readings to demonstrate you how important it is to see the borders. And we have this typical quad screen, which we are using in our lab, and many others use it to do the assessment. So here we have rest, low dose, and on the bottom we have peak and early recovery. So what we want to see with low dose of stress, 10 mics of dobutamine or 25 watts, when you may do an exercise echo, that in systole we get a narrow, more triangular shaped apex and an augmented wall motion with movement of all the segments towards the center of the ventricle. And you see, this is now looking different. So we'll come back to that image in a few seconds. But first, I want to show you what we want to see. We want, of course, LAD ischemia is causing a worsening of the segments motion supplied by the LAD. But what is often more easier to see is the shape, a more Roman arch type or bulging of the apex in systole, and also to see a break point, which is kinking between normal and ischemic myocardial segments. And that's what I have highlighted here. We can see here, highlighted by the red arrow, the break point, which shows you the border of the normally contracting basal and mid septum, and the apical segments, which do not do much, and they seem to bulge out and have this rounded shape. And look at that. This is getting much better within a short time. The heart rate at low dose of immediately after stress was 123, and at peak stress was 129. So we don't want to miss it. We will want to see that. And having the ultrasound enhancing agent in the cavity makes it much easier for us. Another example, again, the apical four-chamber view. And this patient got chest pain at intermediate level of stress. And you see there is no wall motion. This is absolutely normal motion. It looks like at low dose of stress, nice augmentation, no regional wall motion. So of course, with this low intensity of chest pain, you can continue if you don't see anything. But then at peak stress, it starts to be look different. And again, the first thing what comes into your mind is the apical shape in systole looks different. We don't clearly see the break point, but there is one thing what I want to remind you: when you acquire loops during stress echocardiography, always record at least 2. We usually record 4 loops for each stage and for each view. And when you take another view, then it's a little bit later, you can see this abnormal shape here, which is not triangular as it is here. We also can now appreciate a breakpoint. And here you see how we report it. We report the 2 apical segments as akinetic. So another example, again, starting with the 4-chamber view. And in the 4-chamber view, give you a few seconds to decide what you are seeing. And you probably are right. You don't see much. But I show you that because I want to demonstrate something else. I said we measure the ejection fraction with the Biplane-Simpson's method only at rest. During stress, we report on the size of the ventricle. And for that, you freeze the image in end systole. And what you see in patients who usually have a better prognosis, you see a reduction of the LV size. It gets clearly smaller. And there's also some evidence. This is a study from Nelson Schiller's group several years ago on the outcome of patients who have show a smaller end systolic area during stress. There is only a very, very small long-term mortality compared to those who have a reversal where the end systolic area as a marker for end systolic volume gets larger during stress. Now let's go to another case. This is again a 4-chamber view. And here we can see several things. Now, one of the first thing what you may criticize here, we see a papillary muscle. When you do stress echocardiography, you want to have optimal 4-chamber view, and usually you want to cut not through the papillary muscle. In this case, I will show you it has some advantage. Sometimes you can't avoid it, but I'll show you later on this can be beneficial. So we compare now low to rest, and then to intermediate and peak stress. So the next one video shows you what you are expected to see. And you are expected to see first at rest an akinetic basal inferoseptum, and the other parts there is normal thickening, normal invert motion, and no abnormal shape of the ventricle. It augments at low dose, and then you can see at intermediate stress, the mid-lateral wall gets practically akinetic. I should have moved the arrow a little bit closer, but when I put that here, there is not much inward motion here, and you don't see real thickening here. And then at peak stress, we also may appreciate that the basal lateral wall gets worse when you compare it here to the low level of stress. So let's look at the two-chamber view. Again, see how easy it is to delineate the walls and how that helps us to spot the abnormal things. So what are we expected to see here? So we are expected to see, and that's always how we review the images, we take a clockwise journey around the borders of the ventricle. And here we see that the inferior basal segment is akinetic. The remaining parts of the inferior wall are good. Apical anterior wall is good. And we see here an akinetic mid-segment of the anterior wall, and then the basal wall is normal again. And you see that is not much changed. We have some augmentation here at low level, and now you see what's happening here at intermediate. And we did the intermediate because when you look at the heart rate, there was not much change. It actually was a little bit lower here at 10 mics. So we did a 20 mics recordings, and sometimes that's necessary. And what you can see here nicely is how the anterior wall augments, and also augments here in the mid-anterior segment, which again gets worse at peak stress, And what you also can see here, the posterior wall, and I'll have to run it again, the inferior wall, the basal, is akinetic, but also the mid and the apical inferior wall also gets akinetic. And finally, just to show you how you assess then the three-chamber view, it was reported as normal here at rest. You may call that a little bit sluggish, but we called it still normal. Gets better at low dose, even a little bit better at intermediate. And then at peak stress, we can see also that this is not normally coming in. It seems to bulge out a little bit at towards the end of systole. So there is also a worsening here in this wall. So when you compare that, conclude that, then we have akinetic basal inferior wall and inferoseptum, no change during stress. And we have 4 new wall motion abnormalities, and that suggests a high risk study, which we would put into our report. So just to summarize what we are looking for, of course, we are looking for abnormal thickening, but we also are looking for inward motion, which is reduced when a segment becomes ischemic. And instead of that more inward motion, sometimes we can see a moving up and down rather than the movement towards the center. And when you have severe ischemia, you can also see a rounding of the shape, particularly in the basal segments of the ventricle. And here are the findings for the RCA, which are quite similar. What's happening less inward motion. If you see anything more motion up and down of the segments, and also some bulging or rounding of the ventricle. And this is an example. Here is something you have to be aware of, particularly during stress. When you use this sensitive high MI modality for your stress echocardiogram, you may get also an enhancement of the signals in the myocardium, which you can use for additional assessment of wall motion, of the perfusion, but this is not the topic. If that's getting too much, then just reduce the gain or do one flash. But what you can see here, comparison from rest here to peak stress, this is the change in the motion and the shape of the inferior wall. And I have highlighted that for you here in one more image, and also to show another feature which you get with a normal stress echocardiogram setting, which you use for wall motion in that low MI mode. First of all, you see a slight bulging outside. There's no movement inside here up to here. So this is a clear ischemia in the RCA territory. But the enhancement in the myocardium, which we see in the normal anterior wall, is less here along the endocardium. And that is very helpful for you to spot a wall motion abnormality in this area. Now, this summarizes again the findings of an RCA ischemia, less inward motion, passive up and down. If anything, what you see, this is often also not so impressive, and some rounding up of the ventricle. But one thing you should not forget, which is so easy to do, has nothing to do with contrast, is a drop in the TAPSI value of more than 4 millimeters at peak stress suggests proximal right coronary artery obstruction that had been included into the most recent ASE guidelines. And here, just another example of apical wall motion abnormality, but I want to stress one thing. You have to do it right, and that's why you will benefit from later presentation. What you want to have is really a nice, intensive, homogeneous display of the contrast in the cavity. This is still okay-ish, but not optimal. But again, what you can see is the change in size, and also you nicely can appreciate that there is no wall thickening. And you can also appreciate, which is often the first thing what comes into my eyes, is the change in shape. And here we see it then in recovery. Here there's still a very small segment, which is akinetic. Just one last word about assessment of global systolic function. That is certainly something what you can do. You can do it at every stage of the stress echo. But personally, I think this is a waste of time. We only do it at at rest. And during stress, we are only performing a visual assessment, as I said, decrease in end systolic LV size and augmented LV wall motion, and put it in the report. And only when we do have patients for assessment for not coronary disease, but severity of mitral regurgitation, where a smaller change in the ejection fraction is relevant, then we would measure the ejection fraction at each stage and put it in the report. And same for viability and Aslet's heart. But viability is now a rare indication for us. So I want to conclude about the use of ultrasound enhancing agent in stress echocardiography. Hopefully, I have shown you that they facilitate the assessment of regional wall motion abnormalities and EF, reduce the inter-observer variability because the quality is so much better, and increase our confidence to rule in or to rule out significant disease. And this is just another example, 3 apical views where probably all of us would say this is normal. This is certainly normal, but it's not completely normal. When you measure the ejection fraction, this is a lady, then you are already in the borderline zone, or in principle, it's already mildly reduced. And this is because it's so much easier to see everything of the ventricle. And that's what we think what is the border here is not the real border, what we have. So this coming to the end of my talk, and I'm happy to answer any questions later on in the discussion session.
Thanks very much, Harald, for this insightful analysis of wall motions and benefit of ultrasound enhancing agents in detecting and accurately describing wall motion and wall motion thickening. So I would suggest that we save the questions for the end of the lectures, and then we have got joint discussions about all the talks.